Thank you all. Sorry for this troubleshooting. And I think now we can start our meeting. We'll start in just a second. Okay. Good evening, good morning, and good afternoon. I welcome all vascular, phlebologists, hematologists, and all friends along the universe. It's nice to start our program, Phlebology Best Practice. We start our educational program from March to November. On behalf of the Egyptian Venous Forum Board, I am really in debt, and I would like to thank Professor Lowell Kapnick, Professor Joseph Caprini, Professor Eduardo Ramasciotti, and Professor Thomas Mandelando. Also, I would like to welcome our panelists, Professor Mustafa Sulaiman, Professor Muhammad Abdel Mjid, Professor Muhammad Abdel Hamid, I'm sorry, Professor Khalid Dawi, and my dear friend and co-moderator, Professor Omar Farouk. Now allow me to start. I will introduce Professor Lowell Kapnick, our chairman. Professor Lowell Kapnick is a professor of surgery, director of New York University Vein Center of New York, Langone Medical Center, vice president of UIP, immediate past president of American Venous Forum, and is a very, very, very well-known vascular surgeon and with great interest in phlebology, and is a very good helper to our society. I will leave the mic now for Professor Caprini.
Greetings. It's a great pleasure to be with all of you, and a real honor to.
I'm sorry, Professor Caprini. I would like to give the mic for Professor Lowell Kapnick. I'm very sorry, Lord. Professor Kapnick will give a few words before your great speech.
Well, thank you very much, and it's an exciting opportunity to collaborate with the Egyptian Venous Forum to proclamate more information to our fellows as well as our colleagues. And thank you very much for the honor of being chairman. Appreciate it very much.
Great. Now, I would like to introduce Professor Joseph Caprini. He's a senior clinical educator at Pritzker School of Medicine, University of Chicago, Emerite Professor, North Shore University, co-chair of Technical Advisory Panel of GCEHO, ex-president of American Venous Forum, first honorary fellow of the European Venous Forum, and he has a very, very great experience of venous assessment and venous scoring. And of course, today we will enjoy his talk. Now I will leave the camera and the mic for Professor Caprini.
Thank you very much. It's a great honor to be with all of you. It would be nicer even to be there in person, but and also to share the podium with the other famous professors is a real honor for me. These are my disclosures. Now, it's not going to come as any great surprise to any of you that I have chosen for risk assessment the Caprini score. But the last thing in the world is because it has my name on it, because actually it was created by a lot of people much smarter than myself. And without them, we wouldn't have the score. But what's really important about the score is it's the most comprehensive history and physical that you can get that's been validated in 5 million patients in 200 trials. Now, I would ask all of you, if you go to your surgeon, would you want your surgeon for he or her to just go over the high points or to evaluate everything possible in your history so that they could be sure that they could give you the proper prophylaxis for the proper length of time and also the proper informed consent? Because if it's a quality of life or improving procedure such as we're talking about here, then maybe you might not even have the procedure if certain things are there. And the other thing I would say right from the outset is for this group is that, you know, there's 50 million people or more with varicose veins in I think in our country, but all over the world, much, much more. And so thousands of these patients will be done. They're at very low risk. Nothing will happen, but there's a few bad apples in the barrel. And if you don't pick them out, one or more of them could suffer a serious event or die as a result of that. Anyway, on with the Caprini score. 40 elements. We know as the number of risk factors goes up, Fred Anderson has taught us a long time ago that the risk of venous thrombosis goes up. We know that there are different powers to the risk factors. Bed rest is a low power, but cancer of the esophagus or pancreas is high power. So taking the powers and grading them and combining it with the number of factors, we come up with a numerical value. And that's the score that's been validated in 5 million people. And it represents a nonlinear increase in clinical VTE events. So as the events go up, as the score goes up, 1, 2, 3, 4, 5, the clinical incidence goes up. And I would urge all of you to go onto my YouTube site, and if you can't get it, write to me at jcaprini2@aol.com. Several very important videos I've just announced. One will go out next week called The Grim Reaper, talking about the problem of fatal pulmonary emboli. Another has gone out, which will go out showing the deficiencies. The ASH guidelines in 2019, referring to the Caprini score, one paper out of the 200 that were available for evaluation. And so you've got to understand what to do with this Caprini score. The other thing is that the set point isn't 5 for highest risk. The set point varies according to the level of risk of the patient. Now, in general surgery and vascular procedures, it's generally over 8 is the highest risk, and that holds true for varicose veins too. And in patients that have head neck surgery, mostly thyroid and parathyroid surgery, the score of 5 and less, almost nobody has a clot. But yet when you get over 8, it goes to 18%. And in veins and varicose vein procedures, 5 or less is associated with an insignificant amount of thrombosis. As I said, we have 5 million patients and 200 publications, and the largest study so far comes from Vietnam, 2,795,000 surgical patients. And right now I'm working with them. They have a new database with 4 million patients that we're going to evaluate together. And capturing all 40 elements in the score is a time-consuming process, but the collection is facilitated by the patient completing a preliminary patient-friendly form in advance of elective surgery, ideally with the help of family members. Patient's family should assist in completing the score, and the physician or other healthcare professional can then validate the score and put it in your record. And the score is in multiple languages. It's very easy to do, but there's 2 things about this score which are absolutely critical. The first is that it measures obstetrical complications and an unplanned 3 or more abortions, a stillborn, growth-restricted infant with toxemia, with premature birth. These are all very significant historical items in the female patient because they may hide these patients. They are the clinical manifestations for the antiphosphate antibody syndrome, which is a very serious thrombophilic defect that can persist lifelong. Antiphosphate antibody can be a beta-2 glycoprotein. It can be a glucose anticoagulant, and it can be an anticardiolipin antibody. And when all three of those are present, there's a high risk of venous thrombosis. I've seen in my practice and in the past patients with this history, and they have suffered very serious events after minor procedures such as a vein operation. So this is the only risk assessment, to my knowledge, that tracks this. The other important feature is, and there's only the only other risk assessment well, let me back up a minute. There are a couple of the risk assessments talk about thrombophilia markers, and that's not really germane because, first of all, that's not done around the world. It's very expensive, and 90% of people who have a clot don't have a marker, but they still have a risk. So you got to know about their family history, and that's the important thing. To my knowledge, only the National Health Service risk assessment in London, in the United Kingdom, tracks family history of thrombosis along with the Caprini score. And the National Surgical Quality Improvement Project with 7 million patients from the American College of Surgeons. Shame, shame, shame. No past history of thrombosis, no family history of thrombosis, no use of prophylaxis, type of prophylaxis, or duration of prophylaxis. So all of you, please look with a jaundiced eye at those studies from NISQIP that purport to talk about venous thromboembolism. Now, another thing is, which has been missed, and it's historical, and it's again one of my videos, and that is, what is ambulation? Ambulation is the inability to walk 40 feet at one time, and it comes from the Medinox trial from 1999 and the sub-analysis of alpeshamine. Very important to know that. And here's some more factors now that haven't been validated in the official score, but going forward, I'm donating the Caprini score to the American Venous Forum, and there's a large committee there that's going to help to take the score to the next step. Now, failure to account for family history of venous thromboembolism, including known thrombophilia markers, is a potential fatal flaw. This is where you're going to get in trouble if you're doing veins. This is what the patients, they haven't been asked. And here's a study from Scandinavia, which had 183,000 patients over a 25-year period with matched controls, and it's gotten very little attention. And it shows that not only is there an increased risk of thrombosis in the patient who doesn't have a clot, but has a first-degree relative, but also a second-degree relative, a third-degree relative, and even people living together have a slightly increased risk. And part of that is because of the fact that people living together often have the same type of lifestyles. Now, this was an interesting study involving 985,000 patients diagnosed with varicose veins, and 131,000 of them met the study criteria, including 66,000 having multiple therapies, 22,000 with laser ablation, and 16% radiofrequency ablation, and also sclerotherapy. And what it shows here is very interesting, that the incidence of DVT after radiofrequency ablation in these studies, and this is 35,750 patients, 4.86%. And the equivalent in surgical patients, 13,000, was only 3.4%. What's really more interesting, however, is the pulmonary embolism rate after ablation was 0.5%, which was a 50% risk reduction from the over 1% doing surgery. Now, isn't that interesting? Now, another thing that I'd like to discourage all of you, stop using a single dose of low molecular weight heparin. It doesn't do anything. We know there's a 30,000 patient study by Alton in 2012 in the VA system that showed 89% of people got their shot within 24 hours of surgery of low molecular weight heparin, and 11% didn't. There was no difference in the incidence of DVT rate. And this is part of my Grim Reaper video that's coming out this week. 61,000 patients in centers all over the world over the past 40 years have shown that the chance of developing a clot, if you're going to give prophylaxis, you have to give it for the period of time the patient's at risk, which is 7 to 10 days. And it's not only is it useless in low-risk patients, but you can get bleeding complications and allergic reactions. On the other hand, patients, if they're at risk, should get a full course. Now, this was an interesting survey from 230 213 institutions, laser ablation in 43,000 patients. And I put this up, there's about over 200 Caprini articles validating Caprini score, and there's about 20 negative articles. This is one of them. And this falls into one of the common patterns. They didn't collect the data, or they didn't look at it properly. And they found that in the EHIT in 318 patients, 2 EHIT 3 and EHIT 4, as you can see, and 24 DVTs and 3 PEs, very low incidence here. And that's not entirely not true. There is a low incidence in this type of surgery. But in my evaluation, reviewing the Caprini scores indicate that either how to score the patients or incomplete information distorted the results of the Caprini score. I don't see any talk about comorbidities. I don't see any talk about family history. But here's just one example. A 68-year-old woman, BMI which is low, and had a saphenous vein ablation under local anesthesia and sedation. They scored her as 3 points. Well, 2 points for over 60. Varicose veins is a point, that's 3, and a procedure, especially if it's over 45 minutes, is 2 points. The actual score was 5. Here's another one, same story except under birth control pills. Be very wary of people that are also on oral contraceptives, and in this case, the score was 6 and was not properly evaluated. Now, should that either one of these patients had an obstetrical misadventure or had a family history of thrombosis, the scores would go to 8 and 9, and that patient would be at very significant risk. They'd have at least a 10% chance of getting a clot, and I'll show you that data in a minute. And we don't have any idea of all the questions were asked. Now let's go to Poland. 141 patients, my dear friend Tomasz Urbanek, vein stripping and mini phlebectomy, thrombosis prophylaxis with 40 milligrams given for 10 days. Bravo, Tomas. Duplex scans, day 10 and day 30. 5 calf DVTs. So you saw the low incidence of DVTs in that previous study and all those, a lot of patients. And now look at this, 5 calf DVTs, 3.5%. Let's stop here for a second. Everybody poo-poos calf DVT. But don't forget, if a person gets a calf DVT, yeah, their incidence of a proximal DVT, a PE or a fatal PE is very, very low. But it brands them as a clotter. And that predisposes them in the future to getting a clot, another clot. Boro taught us in 1981 with venographic data that if a person has a past history of a clot and they have an operation, their chance of getting another clot could be over 60%. Now, in this study here, the VCSS score and the Caprini score were statistically significant predictors because Tomas collects very carefully all of the patient data. And the authors conclude that risk assessment should be done in all varicose vein patients, and future studies are necessary to confirm these results. Now we go to University of Michigan, 2015, 1,000 limbs. And in these patients, radiofrequency ablation, 1.5% DVT incidence, but adding TIPS procedure elevated it to 3.3. A superficial venous thrombosis, combined procedure, 6.4%, but that's sort of understandable with the TIPS procedure. Remember here, there's a little secret that I like to say that people don't maybe realize, but maybe people taking care of veins understand. If a person comes in with a superficial venous thrombosis, especially a male, and there's no history of or visible varicose veins, that's a very serious situation. In any event, they gave with a Caprini score of over 8, which I think was appropriate. They got 1 week of low molecular weight heparin. They did give a perioperative dose of heparin, and then they imaged at 7 days, 3 and 12 months, and then yearly. And they concluded that axial reflux with TIPS improved outcomes when you ablate with axial reflux. Should be the first-line therapy for varicose veins and a standardized protocol with a low incidence of thrombosis. And their incidence was lower compared to the literature. Now, in 2019, 1 year, that was 2015, those results were earlier. In the year 2019, they had 1 calf DVT. I don't have the number of patients, and I didn't get a follow-up for this year. So now let's score these patients. We score 1 for an ablation, 1 for phlebectomy, 1 for varicose veins, 1 for leg swelling, 3 for a history of superficial or DVT or a family history of thrombosis, or a thrombophilia defect. Now, if the ablation lasts over 45 minutes, the score is 2. 8, 1, 2, and 3, 40, 60, and 75. The BMI of over 25, we score as a point. There's 2 very good studies in the literature. I don't have time to present them to tell you why we picked 25. History of cancer, that's a weak one because we're going to have to expand that in the future. Current and past cancers were all the same. Contraceptives or hormone therapy, and I would just point out tamoxifen, but not Arumadex, because that has not been associated with increased DVT. Pregnancy and a history of obstetrical complications. So now, suggested schema, compression stockings for those people with a score of less than 5. 5 to 8, I'd use 7 to 10 days of low molecular weight heparin. Sorry about that. And then if they're 9 and above, I'd scan them before stopping the low molecular weight heparin. Suggest 14 to 28 days of prophylaxis for family history of thrombosis or thrombophilia, past history of thrombosis or family history, and regardless of the score. Now, the next thing I would like to say is that we would see that naturally I get a phone call. Now, we would see the 10.7% incidence in this beautiful meta-analysis. And I can understand ASH's 2019 guidelines not putting in 150 or so Caprini papers, because not all of them had the high quality that the ASH guidelines demands. But this meta-analysis did. All the original data sets were looked at before this meta-analysis was prepared in 2017. And Panucci clearly shows that if patients have a score of 10, have a score of over 8, their incidence of venous thrombosis is 10%. Now, before talking about the final slide, I'd like to say that collecting all of these data is really a problem. It's very hard to do, and certainly on the fly, it's hard to do. And if you come into the hospital with COVID-19, nobody's going to ask you if Aunt Tilly had a pulmonary embolism. So you must do that ahead of time with your family and then put it in your record. But we have a new secret weapon. It's called artificial intelligence. And right now, the Chinese and also in the United States, they're coming out with a machine learning tool to be able to predict venous thrombosis. And that's going to be the answer, because when we redo the tool, there's going to even be more risk factors. And know all the risk factors is your secret to preventing a death. Now, finally, in conclusion, my friend gave me this advice when I was telling him about the Caprini score. And he said, no, Joe, it's very simple. He said, you have to do doing that thorough history and physical means that stranger that you met is now a good friend. And so you would never, ever hurt a friend, but you would never treat a stranger. So thank you very much for your attention. Please visit my social media sites for more information. And I thank you very much for listening to this.
Yes, it is an honor to be discussing and participating with Dr. Kabnik, Dr. Caprini, and Egyptian folks. And I hold enormous respect for what you're creating there and this gigantic effort for medical education could be honored. Professor Caprini, I don't have slides, but we have tested medical education events like that. We have published at JAMA that medical education reduces mortality for the first time last year. So I'm very happy to be part of this medical education event. Having said that, can you see my slides?
Not yet, sir.
Just give me 1 second. Now, yes. Can you see my slides?
Yes.
Well, I was invited to talk what is new in VTE management in 2021. And when I received this invitation, I thought about discussing about new targets and time of anticoagulation. But as a matter of fact, what is new in 2021 is COVID management. And we have brand new data. And given the fact that I have 15 minutes, I'm going to explore that with you guys and explore what we're planning to do when we're finishing this pandemic thing. And here are my disclosures. I have a fair number of disclosures. I have been working with all anticoagulants. So last year, I was awarded by IOA folks as a good research in the the venous thromboembolism field, and I was asked to list what was major advances in terms of management of VTE in the last 20 years and what would be fantastic in the VTE realm for the next 20 years. And this, they allowed me to keep it pure speculative, and I'll keep like that. So I have listed 5 things, and Professor Caprini, I didn't put the scores on the purpose. They were here, but I removed because we presented about the scores, and they are more than cool for the last 20 years, and they're totally cool for the upcoming years. So they are in the middle, okay? So I think in 2000, a groundbreaking thing was the discovery of fondaparinux. For us here, it's showing very useful because we're suffering lack of heparin. It's a synthetic heparinoid. It was initially tested in the beginning of 2000. I'm quite sure that cancer-associated thrombosis was a major thing that we developed in the last 20 years. Well, in 2009, 2010, we developed DOACs for VTE management, and it's a huge success. We can use it for VTE prophylaxis, we can use it for VTE treatment, we can use it for stroke prevention and atrial fibrillation, we can use for so many things. So I believe the development of DOACs was a milestone in the VTE management. And the vascular treatment, I would put a question mark here. I think we failed with our trials, and we are yet to prove, particularly to clinicians, that we should provide recanalization in the acute phase and the chronic phase, and we really reduce post-thrombotic syndrome. And I'm quite sure Dr. Wakefield and Dr. Comerato won't like that statement, but I think we as researchers are owing something to the medical community. And finally, I believe that we have learned with the scores, with the reversal agents, with better anticoagulation strategies, better bleeding management. So these are the 5 things that happened in the last 2 decades. And most important, medical education. I'm very convinced that medical education is very important, particularly in this area where we're generating so many data. So this is the last 20 years. So now I'm coming to what is new. And we are in 2021, and that's the question. As of now, we are running studies, despite the fact we are in the middle of the pandemic, on new targets. We are not doing factor 12, but we are running studies. We just finished a phase 2 VTE prophylaxis study for a factor 11A oral inhibitor from Bristol Myers Squibb in partnership with Janssen. And we are also studying this new compound for many indications. These are only phase 2 studies. We expect to finish it in 2021 and start moving with this new target to the VTE realm, where probably in the VTE prevention in the medical EU, where we see still bleeds, particularly in cancer patients, we're going to move it to the cancer population. And everywhere where we feel that bleeding is still a major issue. So I think big advance 2021, we are completing the phase 2 studies in the factor 11 inhibition. This is future, and I'm going beyond 2021. I think we will develop better in the vascular treatment for the venous thromboembolism, both in the acute phase and the chronic phase. We owe that to the medical community. Now, I'm totally convinced that now in 2021, in the basic scenario, we are already seeing new targets. We are touching the CRISP technology where we will be able to edit DNA defects. So we will be able to fix in the next years factor 5 Leiden, factor 2 mutations. I'm convinced that in the next 20 years, we will have better biomarkers. I'm totally convinced that prophylaxis strategies that includes better risk score assessment for clinical medical EU patients, for surgical patients, for out-of-hospital patients will help us achieve at some point in the future zero thrombotic events. I'm convinced that genomics and metabolomics will play a major role, but we still need to invest our time in better medical education. digital strategies, and artificial intelligence. So this is the future, but in 2021, we were caught by COVID-19, and the brand new data that we are generating are basically focused on that. And now my next 7 to 10 minutes, I'm going to show you guys what we're doing. We have seen a massive number of patients with both venous and arterial thrombosis, some of them catastrophic. This lady, she didn't respond to fibrinolytic therapy. She died in 9 hours. We tried everything. We don't understand why in some patients this disease is so dramatic. And now we have very strong data that the majority of the mortality out of the acute respiratory failure comes from thromboembolic events. Dr. Klok from the Netherlands published that 31% of the severe patients develop some thrombotic events, and then he published that, and we now understand that severe patients, 50% develop some thrombotic events, the majority either pulmonary embolism or primary pulmonary thrombosis. We're seeing a fair number of strokes, arterial thrombosis, not much of deep venous thrombosis, and a lot of cardiovascular deaths. And now there is, I don't know if in your country you're seeing that, but we're seeing the WhatsApp scientists creating new technology for anticoagulation. And people are creating protocols out of the blue, and anticoagulation didn't escape that. So I think it's out of fear. Here in Brazil, we have reached 265,000 deaths. We are just behind the US, and we are afraid that we will surpass the US in terms of total mortality. And in terms of anticoagulation, this is the question. Should we continue anticoagulation after the patient was hospitalized? Should we switch to intermediate dose? Should we provide this patient full anticoagulation at the moment they arrive at the hospital? So we are tackling it, and we're fine-tuning to come up with these answers. Well, we have published in April last year a kind of guideline. We have put together a lot of information in terms of guideline. And at that point, April last year, we urged colleagues to stick to the best science we had at this moment, do not create anticoagulation strategies out of the blue, and we have asked to follow guidelines, apply the risk assessment scores, and provide the regular prophylactic strategy for patients in high risk and treat patients with events. Well, things have changed a little bit, but as of now, in March 2021, the majority of guidelines are still recommending that ward patients receive prophylactic doses and ICU patients receive prophylactic doses. Only the ISTH recommends for the ICU patients a little bit of increase in the prophylactic dose because we are still generating data to see if full anticoagulation helps or not. We have a fair number of really good trials ongoing everywhere in the world. We are participating on these trials. They are randomized. They are including patients on the ward, patients on the ICU, and even patients at home. I'm going to discuss that. We're testing every single possibility of anticoagulation adjusted by weight, doubling the dose, adjusted dose, enhanced dose. And we are also looking at the best outcomes possible, venous thromboembolism and main all-cause mortality, which is the utmost outcome. And 2 months ago, a group that is joining a platform for anticoagulation and antiviral studies halted three of their trials, the ATTACK, the Active-4, and the REMAP-CAP, because of a very different result. I did not see the numbers yet. It was out of 1,300 patients, but believe full anticoagulation compared to prophylactic helped moderately ill patients, those patients on ward, but not on ventilators and not on air support. So I don't see the numbers, but it seems that there is a decrease in terms of the need to go to ICU and receive oxygen supply. I'm not aware of a mortality benefit. However, if we provide full anticoagulation for ICU patients, it's proved to be harmful with futility in terms of reducing mortality. So it's the reverse to what we have thought, and this took us by surprise a month ago. So look, as of now, we should follow up the guidelines, but we have data coming up in the next days that might suggest us to give full anticoagulation for moderately ill patients and not for those really sick guys on the ICU. And this is the actual statement. This is just a press release. I did not have the chance to look at the numbers because they are not available. From our end here, we just finished enrollment of a very important trial called the Action trial, where we enrolled 600 in-hospital COVID patients with high D-dimer levels, where we randomized them to regular prophylaxis versus full anticoagulation. And on the full anticoagulation, we provided either heparin or rivaroxaban 20 milligrams for 30 days. It's a new idea, and we looked at the best outcome possible, mortality. And then the secondary analysis goes to length of hospital stay and oxygen support. Dr. Caprini, we just finished enrollment of this massive trial, 40 hospitals. We are cleaning up the database, and I think we're going to have results in 15 days, and we're going to publish in a major journal. And I think we'll come up with very important questions regarding full versus prophylactic doses for these really sick people. I'm leading the Michelle trial. It's a small trial here in Brazil where we're randomizing patients at the moment of discharge to see if giving them rivaroxaban or no intervention with the regular thing would reduce VTE-related death, and I have included arterial endpoints such as myocardial infarction, non-hemorrhagic stroke, cardiovascular death, and Mayo. We have enrolled half of the proposed 320 patients. We're doing it in 14 hospitals. We're doing around the clock. We're not sleeping, and I plan to finish enrollment in 30 days for this important trial. We're collecting biomarkers, and now in the US, Janssen is sponsoring a very similar trial, but with a lot of economic support. So they're testing rivaroxaban at the moment of discharge for 4,000 patients. It's called the Prevent HD trial, and enrollment is only in the US, and it's ongoing right now. We're also evaluating patients at home. So if you have a positive COVID test, you are at home and you are feeling well, we're giving these patients anticoagulants in one trial, rivaroxaban or whatever they want, and we're looking at mortality at day 30. This trial is planning to enroll 1,000 patients, and we just launched the Apollo trial with apixaban. So we're testing apixaban twice a day for in-house patients with COVID, with PCR positive, and we're looking also at mortality. To finish my presentation, I leave a big question mark. We're dealing, I think, okay with VTE, but what do we do with arterial thrombosis? I'm seeing one patient a day, like those on the right side. I work in a public hospital here. I'm a professor here. Half of my staff is with COVID, and we're helping the residents. We're seeing 1 or 2 cases a day like these I'm showing you on the right side. And worse, we're also seeing kids. The Chinese folks showed us something they call the Kawasaki rare acute pediatric vasculitis, and then our British folks changed it to pediatric inflammatory multisystem syndrome. But fortunately, it is rare, but in New York, it led to several amputations. We don't know how to manage that. We're giving our kids anticoagulants, and some we are using compassional IL-6 inhibitors. And yesterday, one of my colleagues here called me, sent me these pictures. This is a 8-year-old boy. He had COVID 15 days ago, and he arrived at his office with this acute necrosis. And this is typical arterial thrombosis secondary to endothelitis. It's 2 legs. He sent me pictures for just 1 leg, but it's bilateral, and this guy is going to lose his leg. For these very severe, really sick patients, I'm also leading a trial testing inhibition of IL-17, low dose of IL-2, colchicine, which seems to be a potent anti-inflammatory and cheap drug versus corticosteroid. We're calling it STRUCK trial. We're going to put 300 patients, and as of now, we have 20 patients enrolled for this very important trial. So in summary, I think many great advances are coming for the VTE management in 2021, but by far our greatest challenge is VTE management, thrombotic disorders, dealing with bleeding, dealing with arterial and venous thrombosis. It's tough, but yet interesting times. I think we're getting together as an international community. We're helping each other with all possible generosity, and I'm quite sure that science, good work, will prevail. And to finish my presentation, I would love to quote Mr. Edwards Deming that says, without data, you are just another person with an opinion. Thank you very much. That's it.
And the medical director of Venous Thromboembolic Center. Thank you, Thomas, and I'm sorry for keeping you late.
No problem at all. Can you hear me okay?
Yes, the mic is yours. I will stop sharing my screen. It's all yours now.
Okay, great. I will then, hopefully you'll be able to see this now. Can you see this okay?
Not yet.
Okay, just one more second. I think we'll have it. How about now?
Yes, it's okay.
Okay. So, okay. Well, thank you very much for the opportunity, the invitation, Dr. Fakri and Dr. Kabnik. It's nice to see you all. And it's amazing in these times how we can do these things in the middle of the day here. I'm sort of at work and was ready to accept this nice invitation. So thank you. What I was going to talk to you today was about the Pulmonary Embolism Response Team, what that is, how we've organized it here at my place of employment here in New York University, how it's helped us. I'll talk a little bit about COVID also. I was very interested to hear the discussion about COVID and specifically, how COVID has impacted the PERT or how the PERT has been impacted by COVID. As you can see, I have a couple of disclosures here, but let me just start with the facts. The facts are that approximately 1.1 million people are affected by DVT and PE. If left untreated, we all know that PE has a mortality of up to 30%, which is significantly reduced with anticoagulation. The highest risk occurs in the first week or so, with death usually occurring due to shock, and we know that right ventricular failure is sort of the mechanism for this. 30% of those who die from PE die from the second clot, and therefore anticoagulation should be initiated immediately. So this is pretty standard. The algorithm for treating PE, I think we would all agree, depends very much on how we categorize a PE, what bucket we put the PE, whether it's massive, submassive, or low risk. The way I like to sort of categorize this is simply based on hypotension versus RV failure or versus those hemodynamically stable patients. And you see a couple of the bullet points, which I won't get into too much right now, but some of the general sort of broad stroke algorithms for treating these with, of course, starting IV heparin as soon as PE is suspected. We talked about the importance of that. But then whether or not we're going to go down a thrombolysis versus a catheter-directed versus an open embolectomy pathway, we'll talk about that as well. You can see that this International Cooperative Pulmonary Embolism Registry, which we hopefully are familiar with, published in the Lancet, looked and made us all aware, alerted us to the importance of RV dysfunction with PE. And you can see a very nice graphic representation of the increased mortality rate in those patients with worsening RV dysfunction versus those who have no right ventricular hypokinesis. So this is really the mechanism. And sure enough, massive versus submassive versus low risk has different mortality. And we're all aware that the massive category has the highest mortality, whereas the tricky patient is a submassive that can then decompensate into the massive. And I think we all wish we had a crystal ball that we could predict who those patients might be. And I think this is really where the greatest research should be done. I think again, generally speaking, we talk about rescuing patients with massive PE versus those with submassive. We're talking about preventing mortality and decompensation that would push them into the massive category. The low risk, I think, are all treated just to prevent progression with anticoagulation. The basic strategies as outlined here, I think we try to rescue especially those massive PE, and catheter directed for massive PE can in fact be utilized, and we've started to do that more and more as we are able to treat these using one of the advantages I think of the PERT team is that we can have this multidisciplinary approach and oftentimes avoid a trip to the operating room. Indications for catheter directed as opposed to systemic lysis might be those who have contraindications to TPA, those who have failed thrombolytic therapies, etc. What you see here is the Plato trial. This is a randomized double-blinded trial that compared TPA and heparin versus placebo, and after 7 days randomized these patients. And we would think this would be an answer to our question of whether TPA or lytic therapy was better. And in fact, it did show improvement in death and hemodynamic decompensation in those patients who received lytic therapy. But unfortunately, not surprisingly, these patients also had higher bleeding complications. And you can see the conclusions here that in those with intermediate risk PE, it did prevent decompensation, but had increased major hemorrhage and stroke. So systemic thrombolysis has a questionable risk-benefit profile, I would offer, in patients with a submassive PE. And that brings us to catheter-directed therapy. So catheter-directed therapy, as you can see, this is a quickly evolving field with a lot of exciting new technologies. But what they all, I think, have in common is they aspire to treat the patient and avoid the use of TPA. Granted, we often use adjunctive TPA, but many of these devices, whether it's the Penumbra device, which I am a personal fan of because it's now with the Cat 12 device, is a 12 French, can come from the arm, or whether the FlowTriever, which is another nice device, slightly bigger, 23 French. These are all mechanical sort of aspiration devices that you can utilize fairly quickly without TPA. We all know that the angiojet has a black box warning where it can cause severe hemodynamic collapse when placed in the PA. So that's something that's not really used anymore. AngioVac is another. You can see some specimen from the AngioVac in the top left corner there. So they can really have very dramatic results. But again, the common theme here is to avoid lytic therapy. This is just a case from NYU, a 54-year-old who has a past history of a craniotomy about a year ago with a complex closure. He was scheduled for repeat closure, had a pre-op DVT with an IVC filter placement. Many of our neurosurgery patients present this way. Post-op, he became hypotensive, hypoxemia, and found to have bilateral PEs with right heart strain. I'll talk a little bit about our algorithm for the PERT, the PE response team, but all our patients get an echo right away, no matter what time of day or night, and that really helps us guide management. In this patient, you can see he remained hemodynamically stable, but had some right heart strain and went, after the PERT team was activated, he had become a little more tachycardic, slightly unstable. You see a CAT scan showing some bilateral PEs, pretty extensive, not a saddle embolus, but a pretty impressive radiographic finding. Went to the interventional suite, and you can see systolic pressures were quite high. The right upper lobe here has a very poor flow, and you can see here the left side has also numerous emboli visualized as those sort of hypodensities there. This is a Penumbra device with the separator, and we can actually try to aspirate and use an inner separator to break up the clot. Of course, this can be done from the groin or from the arm. In this case, afterwards, you see a dramatic improvement in PA pressures, and most of the pulmonary emboli are now resolved, and you see the right upper lobe filling nicely. So a very nice result with good post-hemodynamics, with dramatic improvement in PA pressures and saturations, and the patient did very, very well. I'll talk a little bit, just very briefly, on some of these catheter-directed trials, Ultima, Perfect, Optolese, Seattle 2. You can see here in this trial, Ultima, 59 patients randomized to unfractionated heparin versus ultrasound-assisted catheter-directed. And you can see after, a dramatic improvement in the RV-LV ratio when we use the ECOS catheter with TPA versus heparin. In this Seattle trial, also an improvement in the RV-LV ratio in these 150 patients who received TPA. And you see that with unilateral, bilateral catheters, an improvement in RV-LV ratio. This Perfect trial also consistent improvement in PA pressures, very comparable to the Seattle and the Ultima trial. So all these trials sort of speak to the idea that catheter-directed therapy has some improvement hemodynamically and certainly on echocardiogram. When we talk about dosing, I think this is an interesting trial looking at RV-LV ratio after 48 hours according to different doses and duration of TPA that's been infused. And even at the lowest dose, we have some improvement compared to baseline, but as we increase the dose and increase the time, you can see that you have increased in thrombus clearance with increasing thrombolytic drug dose. So the question is, how long do you infuse for? What dose do you use? And you see that there is a response that appears to be dose adjusted here. This meta-analysis I put here because I want to just, again, it would be remiss not to talk about the risk of TPA when used as an adjunct. And you see that in this meta-analysis of 860 patients, there was in fact a significant 0.35% intracranial hemorrhage and 4.65% major bleed. So these are important things to keep in mind. And one of the things driving, the avoidance of TPA. And I think once you have an intracranial bleed, you never forget it. So what are PERTs? Just getting ahead now to the pulmonary embolism response team. These are multidisciplinary teams with expertise in diagnosis and treatment of PE. They generally focus on intermediate and high-risk PE, not the incidental. They don't really get activated for the more mundane, incidental, low-risk PE, more so for the high-risk. We tend to get most of our referrals from the ED, the floors, the ICUs. Occasionally, we will get an outside call on a transfer, but those are always a little bit dicey because if they're massive, they're really not stable enough, and so you have to have that crystal ball I speak about and try to predict which ones will be safe to transfer. We want to tailor both the patient as well as the institution. It's a 24/7 full-thickness team with specialists from all the disciplines, which I'll tell you about. And there are many different models. I'll talk about the one at NYU in a minute. Why is it important? I think there's a lack of real data on to guide treatment of acute PE, especially the submassive. I think there's a lot of different ways to treat this disease. And I think that a lot of our guidelines are really driven by expert opinion rather than by data. These are some of the resources we draw upon, the CHEST guidelines, the American Heart Association, but there's variation here. And I think that PERT can really streamline care. When it used to be before we had a PERT that depending on who was on call, the intensivist or the interventionist or the cardiac surgeon, you would have different opinions and you might have a different treatment algorithm. And I think that's an important part of a PE team is to streamline care and have consensus. These are the members of the PE team at NYU. We have, again, 24/7. We have this sort of 4PERT is the last digits of the telephone number, dial from any hospital phone. It notifies all these services simultaneously, and we're able to then make decisions real time. And then importantly, part of the PERT team is to have a follow-up clinic. So all these patients go to a clinic after discharge where they do 6-minute walk times and they try to assess for pulmonary hypertension and things like that. These are our guidelines. Again, we just developed consensus, but these are sometimes changing guidelines. We generally will determine if it's a massive PE, if they're hypotensive. These are, by definition, massive PEs. We'll anticoagulate if no contraindication. We activate the team. And then our initial guidelines would go straight for open embolectomy. And I can tell you that that's very rarely done, that the majority of the time we will really give it a try with catheter directed for the massive PE. With cardiac anesthesia is very important thing we learned early on is make sure that cardiac anesthesiologists are there, preferably in the hybrid room where we can convert to open if we need to. The submassive guidelines, we really want to do that echocardiogram, which helps determine whether these patients are submassive. So we'll get an echo no matter what time of day or night. We'll try to determine the RV dysfunction if it exists. Of course, we measure cardiac enzymes, et cetera, and lactate to determine end organ damage. And then here's where we have the discussion, and oftentimes we will treat conservatively and watch the patient. And I'll show you some data now in our experience, which is a little surprising because we're not as aggressive as some centers. And we don't always go to catheter-directed. We choose to watch with anticoagulation first and see how they evolve, and then make a decision. We have, of course, the PERT consortium, which we're a member of, and this is a multi-institutional consortium that has is aimed to collecting data and eventually helping back up some of these guidelines that are to come. I think it's an important effort. This is sort of part of a venous thromboembolic center that we've established a number of years ago, the PERT team. But we do a lot of data collection. We have full-time research staff who go around, enrolling patients in trials and collecting our data. And so it's a real team. This is the sort of stickers that exist all over our emergency rooms and our other satellite hospitals that people can very easily activate by calling this number, and we can very quickly then use a phone system to connect all the players. The send word now is what we happen to use. It's not important, but it's a technology that really quickly connects all of us no matter what time of day or night. This is, again, sort of one of these stickers that you'll see in the ER and how the PERT team is organized and who gets on the call. We have about 14, I'd say maybe 14 to 20 activations a month, the majority from the ED. And these are some of the treatment algorithms I talked about. This is the clinic I alluded to, which is this outpatient clinic staffed by some of our pulmonologists, where they look at medication, maybe refer to hematologist, again, reassess RV function, whether they need to have the filter removed. That's another important goal of ours, is not to have these sort of orphan filters that we oftentimes see left behind. I think that's an important part of the clinic. And then research, right? We collect a lot of data and follow up there. This is a paper we put together on our early experience with the PE response team. And in this experience, you can see we had 179 patients in our early since inception. We had an average of 8-minute response time where all of our services got on the phone together. You can see, again, I mentioned the majority from the emergency room, some from the ICU. Massive PEs accounted for about 8% of our activations. And again, PE team was not activated for the more mundane low-risk PE, but for the submassive or the massives. Some of our interventions shown here, all patients really received anticoagulation, but about 90% just had anticoagulation alone. I mentioned earlier that we do very few embolectomies, and our catheter-directed interventions are also fairly few. Only about 5% had catheter-directed. Systemic TPA and 3%. Here's something I think very surprising. At first, I was a little bit put off by this, that our time to intervention was 665 minutes. That's a long time before a patient gets to the IR suite or to the operating room. And we thought about this a lot, and I think it's really because we believe in sort of a very careful surveillance of these patients and monitoring, and then determining whether they're going to improve or not. And only when they deteriorate do we start to sometimes think about taking them to CDT. We use the echocardiogram as a tool to really guide us. You can see that of those who had evidence of right ventricular strain, there was a 15 odds ratio to get some sort of catheter-directed therapy or TPA. And you can see those with those who had right heart strain, 21% underwent advanced therapy, and then 78% continued with some sort of conservative therapy. Here's some of the outcomes. The majority were submassive versus massive PEs. And you can see here that systemic TPA or catheter-directed therapy was performed often in the massive. So not so much the embolectomy, the open surgery, but we would really rely on catheter-directed for the massive PEs. Of course, those patients had more cardiac events, but interestingly, the cardiac events for the massive occurred before the intervention, so it was not really a result of the catheter-directed. It was really predated or a priori to the intervention. Bleeding was still a problem in some of these catheter-directed treatments. You can see in hospital deaths of 8%. Only one who received catheter-directed TPA died. This was the one I mentioned with the subarachnoid bleed. I'll switch gears a little bit to the COVID era, and I think this is interesting. We looked at our experience in COVID versus pre-COVID vis-a-vis the PE response team, and we looked at this and found in the COVID era, patients with PE were younger. They had less known, there were fewer PE risk factors, including malignancies. They occurred later in patients in the hospital course, despite being on VT prophylaxis and less contraindicated. So, in other words, patients in the COVID era, the PE response team was activated more in those who were non-COVID positive. So whether this is because there's this chaos factor, I call it, where we really didn't know what to do with the COVID patients, or whether there was more experienced critical care intensivist in the hospital and they felt they didn't need to rely on the PE team and they can make maybe decisions on their own, there were fewer activations. You can see the pre-COVID era, there was 64% of patients had activated PERT versus 26%. We had more catheter-directed interventions. We had really no catheter-directed interventions in the COVID era. Length of stay increased in the COVID era, but you can see that overall 40% decrease in PERT activations during COVID, activated for females, those with DVT, anticoagulation, those who were negative COVID. So length of stay, interestingly, in the COVID era, those who had no PE activation had longer length of stay versus in the COVID era versus the pre-COVID era. So again, something about selecting those patients for PERT activation shortened their length of stay. So I think in conclusions, the PE response team facilitates good delivery of care. It prevents this unilateral decision-making that can otherwise occur. The time of activation to our multidisciplinary conversation was very low at 8 minutes or so. Standard of care, anticoagulation is the predominant treatment of choice, and we're very selective about when to use catheter-directed therapy and TPA, but they are safe and adjunctive treatments. We rarely perform open embolectomy. I think COVID appears to have resulted in a higher threshold for intervention at our institution, but similar outcomes. And I think reasons for this is speculative, but I think ultimately PERT teams only operate at the discretion of those who choose to activate them. So if you have a lot of sick patients and there's not a good standard of care for how to treat these COVID patients, they have other problems. Maybe that's guided why they have not activated PERT during COVID. A lot to learn about COVID, obviously. So with that, I want to thank you for an invitation. I know, I'm not sure what the next agenda item